Hi, I just wanted to get a bit caught up on our topics so that we can actually start fresh with cardiovascular alterations on Tuesday. So I thought I would finish up the rapid response series in this recording. And I believe this is the slide we left off on. This is actually a slide from American Heart Association. They do guide a lot of the resuscitation efforts that are utilized in the hospitals across the country. And I was a employed for that department for a few years and regularly taught not only basic but advanced cardiac life support. I taught pediatric life support, and I did a lot of the mock code in situs where we would go to a location within the Cleveland Clinic enterprise, and we would bring a mannequin, whether it's an adult, a child, or an infant, and we would have that staff resuscitate the patient in their own environment. So they were using their own supplies, they had to go get their own equipment. And it was kind of a test to see, not a physical test, but like to test their system to see were they missing anything? Could they find everything they needed? Did they bring everything to the situation? Or were there some barriers like nobody could find the stool, or they didn't have the right size ambu bags, or the ambu bags that they had were expired? So it was a bit of checking and double checking, and we did uncover quite a few issues that you know we were able to report to the administration, so then they could resolve those issues before there was an event that could potentially affect a patient. All right, and we will be working a lot with the ISBAR that was developed by Team Steps. That's why I put the little Team Steps cartoon there with the penguins, but in communication. And Team Steps is used in the SICU at Metro Health. So the students that are assigned clinicals there will get quite fluent in the Team Steps program, but they, as far as like the nursing part of team rounds, is quite extensive there in the SICU at Metro. So please take advantage of that and take the opportunity to present your patient in rounds. It will help you feel more comfortable interacting with the provider level of the team when you're out and about working on your own. So this just really helps get over that hump of, oh my gosh, I'm afraid to talk. But all of the facilities that we are at are teaching. So any opportunity you get to speak to one of the team members is great. But the idea behind the ISBAR is to kind of get to the bare bones of what the problem is, why you're calling. So, you identify yourself, your patient, where you're calling from, maybe where you're calling from, because many providers may cover various areas. You could be talking to the night person who has to cover, like several floors or something. Then you're going to relay the situation, the background that's pertinent to that situation, not all of the background. And then it's your assessment of the situation, not your physical assessment of the patient, but your assessment of the situation. And then you can include your recommendations. You may not exactly know what you want. You may have some ideas. You could always share those. They can, you can have some dialogue and some collaboration about what's going on, but this is a very quick, effective way of getting to the bare bones of what is the problem. All right, so this is a typical crash cart that you might see in various hospital locations. You can see the little blue plastic clippy things that are on the bottom and on the right side. Those literally just pull off. You have to, break them off, but they keep the materials inside the cart locked so that those materials are there when you need them, as opposed to them disappearing throughout the day or the shift. And then when you have an emergency, if your cart say were not locked, who knows what's in there by the time you actually need the equipment. So most of the hospitals, I think, use like a central supply to restock these so that they're all stocked the same, so that you could go anywhere in the hospital system, maybe in the enterprise, and find the same equipment. So you become familiar with what's where. You can see there's lots of labels. They kind of tend to be labeled by overall content, like usually there's a respiratory drawer. Maybe there's like kind of an IV venipuncture drawer. Um, the bottom drawer tends to have the big items like a suction, in case your patient arrests or has an emergency in an area where there isn't bedside suction, like maybe CAT scan or in the hallway. The backboard is generally hanging on the back of the cart. There, as you can see, there's kind of a bit of an IV pole on the back. I don't ever see people using that for patients, but I guess you technically could. So if you ever see a cart that's open, you can always, after the emergency's over and before they send it to central supply, kind of check it out, open the drawers, look at what's where, what it looks like, kind of familiarize yourself where the materials are. And for the most part, you want to know where your crash cart and where your defibrillator are on the unit that you're at, because if there's ever an emergency, you want to know where you can find it. You don't want to have to think, oh, where did I see that? Additionally, in the ICU areas, the Zoll or whatever your defibrillator model is that you're using, they're generally on a separate cart. So I think they try to keep them close together, but it doesn't always work out depending on, how things are in the hallway. But, that's definitely something good to be familiar with as well. So some of the medications that we will see during the code, the idea with most of the medications are to kind of reinstate or, have optimal function of the heart muscle and your body hemodynamics. Many times we're correcting the oxygen status or possibly like CO2 or acidosis within the patient's body. And with our big cardiac populations that we see, they tend to have more arrhythmias. So there are medications, antiarrhythmics, that can suppress this activity. So the common meds that we see, oxygen, which we do count as a medication, adenosine, amiodarone, lidocaine can be substituted for amiodarone, atropine, epinephrine, magnesium, and sodium bicarbonate. So we'll talk about each of those for a moment. Oxygen. So talking about the EC clamp technique, this is something that you can practice in the skills lab, or I'm sorry, in the nursing lab. So you can always practice this with one of the TAs or whomever, but you may be able to have an opportunity to practice this in your clinical site. But the thumb and the index finger make the C that goes around the mask. If you look at the diagram above, makes the C that goes around the mask, and that's how you apply pressure down on the patient's face so the mask has a good seal. And then the E are your middle ring and pinky finger, and those are what grasp the bottom of the mask and the patient's jaw, and that's what allows you to do the chin lift. So you're pushing down with the thumb and the index finger while you're lifting their jaw. It does take some finesse to learn how to do this so that you don't have a leak, but this is an easy technique that we recognize and that American Heart Association recommends. So, if you are using the bag valve mask or the AMBU bag or the BVM, whatever you want to call it, there is an oxygen tubing that you will hook up to the flow meter that's attached to the wall, and you're literally going to turn it all the way up. We're not concerned if we're bagging the patient, they're not breathing or they're agonally breathing. So we're really not concerned about their COPD status, and if they're a retainer, we really just need to ventilate them. And during CPR with the bag valve mask, that is a basic airway, And so you would use the 30 compressions to 2 ventilations. You do need to stop the compressions to give the breaths because it's very hard to blow that air in to the patient's lungs if someone's pushing down, giving a compression. It's really hard to do that. And, the seal is not going to be that good then. It's going to be difficult. They're going to be difficult to bag, and we don't want that. Now, if you have an advanced airway like an endotracheal tube, there's a balloon partially down the tube that actually helps to control what you're pumping into the patient with the ambu bag, because you would take the mask off and then attach the ambu bag directly to the endotracheal tube. So when you squeeze, it is literally going right into their lungs because the balloon controls air that it doesn't allow air to escape out around it or around the endotracheal tube. So in that situation, you can do 1 ventilation every 6 seconds, which ends up being 10 breaths a minute. And most people, even our respiratory therapists, tend to do that faster. I personally have to count in my head. I know I would ventilate faster if I wasn't counting. So, and the reason we don't want to overventilate, there are some downsides to that. You can actually increase the intrathoracic pressure in the chest cavity, which decreases your cardiac output. And the patient's cardiac output is already decreased if they're receiving compressions. So we want to optimize that cardiac output. So we want to allow for that pressure to kind of be reduced so that when we are compressing against the heart, the heart between the sternum and the spinal cord, we want to get the best compressions we can. This is a video that you can watch on your own time. You just click the link and it shows how to properly use the bag valve mask. All right, so oral or nasal pharyngeal airways. These help with bagging. Pretty much if you're bagging somebody, you should probably have one of these in if you're using the mask ventilation. And the reason is if you look on the left at the oral pharyngeal airway, it measures from the mouth to the angle of the jaw. That's the correct size. They do come in various sizes, and if it's too long, it will be sitting in your airway. If it's too short, it could be pushing your tongue back and occluding your airway or partially occluding your airway. So the size does matter. And the bend in the oral pharyngeal airway, that's what holds the tongue forward. So it can't flop back and occlude your airway. So that supports the tongue. You can imagine if you had that in the back of your throat, that if the patient had any reflexes, they would be gagging, right? So we would not put this in a patient who is gagging. If the patient seems unconscious but starts gagging, then you would have to switch to like a nasal pharyngeal airway if you need one, because we can't have the patient gagging and aspirating. The nasal pharyngeal airway for the little boy on the right, that is also something that gets measured, and it gets measured from the tip of your nose to the tragus of your ear. And again, the diameter of the tube does kind of get larger as it gets longer, based on just average size, but these do go into the nasal pharynx, but they don't cause a patient to gag once it's sitting in there, once you have it inserted. They might gag or be disturbed while you're putting it in just by the process. But once it's sitting in their nostril, they really shouldn't be bothered by it. But you could insert this in a patient who did have some reflex, was semi-conscious or conscious. Okay, so adenosine Adenosine is given for supraventricular tachycardia. It is 6 milligrams IV push, and then it's followed by 20 of saline. This medication has a very short half-life, so we have to get it to the heart before it starts breaking down. And the way that we do that is we want to use the IV that's closest to the patient's heart, and we should be using a stopcock because that shortens the time. You're less fumbling with trying to unattach a syringe, attaching a new one, unattaching and reattaching another one. So this definitely speeds up the process. So the majority of the time, if this is being given in a non-ICU area, they should have the patient hooked up to a 12 lead so that they can monitor. But what you may see is actually like a slowing or a stop, because the whole mode of action is, it slows the conduction through the AV node. So in that case, they might, like the team may then be able to identify what is the cause, like what is the underlying rhythm of the SVT, and then it may help them be able to better treat this. But they will start with 6 milligrams. They may repeat it every minute or so, and by giving a 12 milligram dose and then followed by a another 12 milligram dose. In general, that's kind of the stopping point. By then, maybe you'd have some expert consultations there so that they would be able to better guide what's going on, with this patient and where to go forward. But usually I warn the patient that they may actually feel that kind of stop in their heartbeat, not to be concerned. It has a very short half-life, so it doesn't, last very long. But we do generally like to have them, we're closely monitoring these patients to make sure that they, the heart rate does return. And next is amiodarone or cortisone. Looks like on these bags it's called Nexterone. So there's different brand names. But this medication, it is available in pill form, but for emergencies like we may see in the ICU setting, we can give boluses. And if the patient has no pulse, like with VTAC or pulseless VTAC or VFib, they will just push 300 milligrams, which is 2 vials. Now, the reason is because there's no pulse. So you're not really concerned about their blood pressure because they don't have one. If you have a patient who has a blood pressure, then it's going to be mixed in a bag of 100 milliliters, and you're going to infuse that over 10 minutes. And again, it's because they do have a pulse at that point. And this is an antiarrhythmic type medication, so it reduces the cell excitability and prolongs the action potentials. And because of that, that could terminate the arrhythmia. Doesn't always work immediately. It might work a little bit down the line, but in general, this was originally developed to be used with ventricular arrhythmias like VTAC and VFib, but in the meantime, now we use them for atrial rhythms as well. So you may see them being used for either. And then the bag on the right, the 360 and 200, that's a common concentration for like infusion, and it's generally given 1 milligram a minute. Guidelines say 1 milligram a minute for 6 hours, and then 0.05 milligrams a minute for 18 hours. But that will vary on your institution and their ideas. Again, some of these are like guidelines from American Heart Association. This medication does need an IV filter, which is displayed on the bottom left. And again, this is an antiarrhythmic, so lidocaine is an alternative. But the reason why there's a picture is because for patients who use long-term oral amiodarone, there is a possibility of a blue pigment change over time. But they also screen patients pretty heavily because it can cause chronic pulmonary disease over time, pulmonary fibrosis, and elevated liver enzymes and vision changes. So it's not without its own risks. Atropine, we give 1 milligram IV push now. You may hear people saying 0.5. That was the amount that we had given previous to 2020, and maybe not everybody has gotten the update from American Heart Association about the ACLS change to just do 1 milligram, which is the whole syringe in this picture. In general, you'll find atropine in this purple colored box, and you can give it every 3 to 5 minutes for a maximum of 3 milligrams, which would be 3 syringes. So that makes it kind of easy with the math. And what it does is it increases the SA node and automaticity and the AV node conduction. So it speeds it up. It's considered an anticholinergic. And it, when we give it, is for patients who have symptomatic bradycardia. We don't give it for asymptomatic bradycardia. And this may not work in patients with lower degree heart blocks, like second degree heart block type 2 or third degree heart block. But, not everybody is a cardiologist and can discern the difference between those AV blocks in an emergency situation. So the idea is, we're just going to give it. It's the first line medication. And if it doesn't work, then we're going to move on to another option. But if you could imagine patients who are having myocardial ischemia, this is going to increase their muscle demand, and this could make their MI, if they're having any kind of chest pain or oxygen issues, this could make it worse. So we really do want to avoid atropine in patients who are actively having an MI or under suspicion for acute coronary syndrome. Transplanted patients, they, the nerves and everything are in question. So it's possible that the nerves could have been reestablished that connect to the SA node and the AV node, but they may not have. So, and I don't know, like percentage wise, how often that can happen, but in general, patients who have transplants, they may not respond to atropine, and that would be why. All right. What else do I want to say about atropine? It may induce a tachycardia, obviously. Okay. But patients that you may be seeing with symptoms, those are the signs of poor tissue perfusion. So that's, chest pain, shortness of breath. It could include mental fogginess, altered mental status, could include low blood pressure, signs of heart failure. Those are the types of symptoms we're talking about. What would make them symptomatic or unstable? All right, epinephrine usually comes in this, I don't even know what color to call that. It's kind of like it's not even tan, I guess, but like that color is synonymous with epinephrine. And if you can read the box, it says it's a 1 to 10,000 solution. 1 milligram is 0.1 milligram per milliliter. So basically, each of those Bristagets in the center there, they have 10 milliliters worth of fluid in there, which is 1 milligrams worth of epinephrine. So if they call for 1 milligram of epi, you're going to give the whole thing. And that is the general dose, 1 milligram of epi every 3 to 5 minutes. This stimulates both the alpha and beta cells. So not only does it increase your heart rate, it improves your contractibility, it improves automaticity, it can tighten up those blood vessels and help vasoconstrict, so you get better blood flow. So it will increase your blood pressure and improves coronary and cerebral perfusion. It can also make your heart a little bit more sensitive to a defibrillation. So side effects, clearly you're going to expect them to be tachycardic afterwards, and possibly, depending on how much epi you've given them, may actually end up going from hypotension to hypertension. And it can lead to myocardial ischemia because of all of those wonderful things that it does do. So we do give it, anybody who does not have a pulse is going to get epinephrine. So you can just pretty much get that ready. Epinephrine does come in another concentration, 1 to 1,000, and that is the dose that they use if they're making an epi drip, or that is the dose that they use for anaphylaxis to inject IM. So that's why there's 2 different concentrations. And in general, IV infusions of epi are 1 to 10 mics per minute, and it can also be given down the endotracheal tube. In general, if you're giving something down an endotracheal tube, if you don't have IV access, it's 2 to 2.5 times the normal dose. So instead of giving 1 milligram of epi, you might be giving 2 milligrams of epi, and you're squirting it down their endotracheal tube. It says to mix it. Usually you would mix it with some saline, but if you were giving this concentration, it already is mixed in saline, so that wouldn't be necessary. But you would just aggressively bag the patient and try and get that liquid in into the different areas of the lung tissue so it could be absorbed. Magnesium, you can see our nice little ECG tracing of torsades. And magnesium does come in vials and bags, IV bags. We generally don't push IV magnesium, but if the patient has no pulse, it may get pushed in a code. Otherwise, it's going to be diluted in an IV bag and administered. And, in general, when we give IV magnesium, maybe it runs over an hour or 2, right? But in a code, you may be, if they have a pulse, you may be giving it very quickly, like in 5 to 20 minutes instead. So it varies whether they have a pulse or whether they do not have a pulse, kind of how quickly you're going to give it. I know the worksheet says that we dilute it in 10 milligrams or 10 milliliters of D5W and push it over 5 to 20 minutes in a code. I think you can check with your pharmacist on that, but I have definitely seen it given IV push, but it looks like recommendations are 5 to 20 minutes in general for a patient with no pulse, and for a patient with a pulse, you would mix it in an IV piggyback bag like a 50 or 100 and give it over maybe 5 minutes or 60 minutes. You could set that on a pump to infuse, but it can cause hypotension and bradycardia, respiratory depression if it's given too quickly. So it's not without its own risks. And magnesium and OB is entirely different, and I'm not familiar with how it's given and the different modes. So this is specific to, adult patient populations. All right, so sodium bicarbonate. You can see kind of the picture on the right. It does precipitate. It's very alkaline, so it can precipitate with other medications. It's usually something that you want to give separately, and if you have to give it in a line that other meds have been given through, you probably want to flush with some saline, give your bicarb, and then flush with your saline after, just to make sure that you don't have any precipitation, don't have any contact. But clearly, this is given for states of acidosis. whether it's metabolic or respiratory. In a prolonged code state, they may become acidotic because you're not generating, your cardiac output is not as good. Your compressions are not as strong as what your heart would normally pump at. So you may have some code-induced acidosis. So they may just give some bicarb because the length of the code. Sometimes they use this in certain overdoses, and we definitely use it in hyperkalemia. So, what else? It's usually a lot of times they'll just order an amp, which is the whole 50 milliliter syringe. It's also a Bristajet syringe, but it can come in very large vials that are 50 milliliters too. But this is the common dose for in like code management and such. And precipitation, if you look at that picture, it's where the medication interacts with other things that are in the fluid and can actually cause like little crystals to kind of form. And that's what that cloudiness is there. And clearly, if some of that went into the patient, that's like an embolus basically floating around in the bloodstream. So we don't want precipitation. Say you can't get IV access, or the IV blows, or you need more. Certainly, the fastest way to get another type of access is an interosseous, which is an IO. And that's what the picture is of the little drill thing on the bottom left. There's different sizes, different lengths and widths. They're literally going to drill it into a bone. There's methods of assessing the bone and deciding where to place it, but some common bone locations are the top of the tibia, the top of the humerus, and even the sternum. But the humerus is kind of a busy place in a code, as is the sternum. Plus, having one in the sternum could be challenging if you're doing compressions. So I think most of the time the tibia tends to be the location of choice. And you can watch videos on YouTube. There's pictures of different providers drilling IOs into each other. Really your bone is not I realize when your bone breaks, that's very painful, but just this tiny little drill, it's not supposed to be very painful. And honestly, if your patient is compromised, they may not be feeling that anyway. It does kind of maybe look a little barbaric, but they're just drilling through the outer part of the bone till it gets to the like medullary canal. And then when you give medications through the IO, it's exactly the same as giving it IV. So there's no type of a conversion. Anything that you can push in a vein, you can push into the osseous. Now, when you do use an IO, initially, you're really not going to use this as a source of like getting blood, because some of those little bone fragments and chips that when you drilled in could be sucked back into the lumina of the catheter and then clog that access. So you're really just moving things forward through it. And the other thing is, if you're giving like a bolus, some patients will say that the pressure of that fluid moving in can be uncomfortable. So, consider that what you're using that access for. If you have another access, you may consider what's going where based on they may feel some of that pressure. And then, like I talked about earlier, you can give some medications down the endotracheal tube, like atropine, lidocaine, and epinephrine. And again, the general rule of thumb is 2 to 2.5 times diluted in some saline. This is just an example of a transport monitor or a Zoll. This is a Philips. These are the ones that we had before the Zolls. I don't know if Philips is still making these monitors or not, but either way, there's different settings on here, and I'm actually going to bring one of our Zolls into class on Tuesday and go over it because someone was asking some questions about it, and I thought that would be good to go over it. Defibrillation versus cardioversion. So they're both a form of electricity or energy. If you have no pulse, you're going to defibrillate. The reason why is defibrillation is happening. The patient has no pulse. You don't need to synchronize anything. It's just going to release the energy as soon as you push the button, the fastest it can. So that's patients who are in VFib or VTAC without a pulse. It doesn't matter where in the cardiac cycle that energy gets deployed because, again, they have no pulse. Now, if you have a patient with a pulse and, they're unstable, or even if they're stable, either way, they have a pulse. So in that particular situation, you do want to synchronize. And that's the difference between cardioverting and defibrillation is you're synchronizing with the cardiac cycle. And the energy, you'll be, say, pushing the button if you're cardioverting, and the energy is getting released on the R wave. That's where we want it to get released, on the R wave. We do not want it to get released on the T wave, right? Remember how we talked about R on T and prolonged QT and how it's very detrimental to release energy during that phase of the cardiac cycle. And PEA and asystole are not shockable rhythms, regardless of what you see on TV. We do have two different types of defibrillators. Majority of them are biphasic now, but if you're working in a cardiac area, they may still use like the monophasic, and that's very specific to their specialty. Or if you have like an older squad and they just haven't like purchased the newer equipment or that kind of thing. But in general, I think the majority of hospitals and all of the hospitals that we're at are going to have biphasic defibrillators. And you can see by the pictures, it delivers energy in two directions versus just a single direction. And so that's found to be more effective. And also it uses less joules. So in the olden days, with the monophasic, the joules went up to 360, whereas biphasic goes up to 200. So if you're going to defibrillate a patient, obviously CPR, you've already gotten past the, hey, are you okay? I need some help in here. Call 911 or get a defibrillator or code blue, checking for a pulse for 5 to 10 seconds, finding no pulse, starting compressions, getting them hooked up to the monitor. So that's when you can actually see what their rhythm is. And at that point, you'll know if you have a shockable rhythm or not. You do want the pads to be in good adherence to their skin. We don't want it over an IV, over like a topical skin patch. If a patient has a skin patch where you're going to place the pads, take it off. You might want to take the patch off anyway, but either way, it can cause some burns because of the conductivity. But also, you don't want to place it over a pacemaker. I think it can probably damage the pacemaker, but the pacemaker also blocks the energy that's coming out of that pad. So we don't want to reduce the amount of energy. Okay, so we've got the pads on. They have good conductive media. I think it's better than using paddles in most cases. But then whoever's in charge is going to say how many joules, or if you're using an AED, it's going to pick it for you. And then, the common mnemonic is I'm clear, you're clear, everybody's clear. But not only are you saying it, you're looking around the room and making sure nobody's touching the bed, nobody's touching the patient, that the airway person is backed away from the bed or cart, because they're usually the ones who are in most jeopardy because they're squeezed in behind the wall and the bed. If you were using paddles, you can't just place them on the skin. You actually have to push down, and that can also, you're pushing down against slippery conductive jelly. So, it's a safety factor too, using the paddles. It's better to use the pads because it puts you in closer proximity to the patient. You could then accidentally be touching the bed. So, once you say, you make sure everybody's clear, you can put your finger or thumb on the button, and then, the monitor's not going anywhere or the defibrillator. So you can literally like push the button while you're still viewing everybody and making sure that they're not touching the patient. And then the shock will be delivered instantaneously for the defibrillator because it doesn't have to time with the patient's cycle. And then you're going to do CPR for 2 minutes and reassess the rhythm. Ensuring safety is huge here. Whoever's pushing the button is really responsible for the safety of anybody in that room. Here's some pictures of, anterior post placement. And the pads generally have pictures of which one goes over the heart and where the other one is going to go. This is a picture of anterior posterior. And yes, sometimes you do have to work around women's breasts to get that in the right spot, or men with hairy chests. If you're concerned about not having good conductivity because of hair on the chest and you have 2 sets of pads, you can literally put a pad on and rip off that hair and then put the fresh pad on. I know it sounds awful, but if you're having to defibrillate somebody, they're not feeling that at the moment. Cardioversion, like I said, it does synchronize to the R wave. Generally, less energy than with defibrillation. I think you saw with defibrillation, it's maximum with a biphasic monitor to go up to 200 joules. In general, like with SVT, you generally start with 50 to 100 joules. With something that's difficult to cardiovert like AFib, sometimes you start at like 120. But again, these are things that, I don't expect you guys to know like the number of the joules, but cardioversion does generally start with less energy. Okay. And by releasing the energy on the R wave, giving it during that depolarization phase, it disrupts wherever this arrhythmia is coming from, and it gives the SA node a moment to kind of not necessarily like reset itself, but to pick back up so that it's the primary pacemaker again. You may want to consider the pain the patient may feel with this. You may want to consider it. It doesn't mean the patient will get sedation or pain medication, but maybe they will. Depends on their mental status, depends on how unstable, depends on how quickly it's going to take you to get that medication and bring it in the room, because we certainly don't want the patient to decompensate further to where they do lose their pulse. And if we give pain or sedation, and throughout the cardioversion, we do want to monitor their airway. We may want to put them on some kind of an oxygen source just for the time being. And we do want to explain to the patient what's happening and what's going to go on. Transcutaneous pacing, this would be as what it says, it's going through the cutaneous or the skin layer, and it travels from the pads to the patient's heart. It can cause muscle contractions just throughout, like your body in that area, because it's not specific to cardiac cells. It's, going to cause any kind of muscle to contract. In general, this has to be anterior, posterior, because the electricity is traveling through those pads, and so they need to kind of be over the heart. We set this in a demand capacity, and what that means is it's going to kind of, we're going to set it so that it's going to deliver like a rate, and it will count or keep track of the patient's own heartbeats if they're having their own heartbeats. Maybe their heart rate is like 30 and you want to get to 80, so the pacemaker should give an extra 50 beats. You can adjust the milliamps, which is the energy, And you may see a spike followed by a QRS, but that's what it should look like on the monitor. In general, like the QRS that follows a pacer spike in this transcutaneous method is going to look wider and bizarre, kind of like a PVC, if you will. And the reason is it's traveling in a different pathway than our SA to AV to, the myocardial cells. That's the super quick, nice pathway. This is an alternate pathway, so it's going to look different on the ECG tracing. But just because you see a spike does not mean that you're getting that the myocardial cells are actually contracting. You would want to check for a pulse and make sure that the pulse is corresponding with the paced beats, with the pacer spikes. And that's how you know you have mechanical capture, right? If you see a spike and then a QRS and then a spike and a QRS and a spike and a QRS, and you can feel that pulse, then you can feel pretty confident that you've got mechanical capture. But if you see a spike and then a spike and a QRS and it's not synchronizing, then you may have to turn up the energy to get it to have mechanical capture and cause those muscles to contract. Now, this is less energy than getting cardioverted or defibrillated, but it still can be uncomfortable. So they generally, don't leave patients on this for any length of time, especially at the 3 hospitals we're going to be at. They're probably likely going to put in a can't think of the word. They're going to float in a wire through the jugular, I think, and transvenous, I'm sorry, through the jugular vein, having a blank there. They'll undoubtedly float a pacer wire through the jugular vein and, wedge it into the patient's right ventricle, and do pacing that way until they can decide, like, what is the cause? What is the problem? Is this something that is reversible? Like, did they take too many beta blockers? Are they, what's going on? Or is this something that they're going to need a permanent pacemaker for? This is a paced rhythm. This does look like it probably has electrical capture because it has a spike and a QRS, a spike and a QRS, a spike and a QRS. So it looks good. And as you can see, it does look like it has a really weird QRS and a tall T, and that's normal. That is normal what a paced rhythm looks like. It's got to travel through all the muscle, skin, and bone to get there. So the ACLS, Advanced Cardiac Life Support Algorithms, which you do not need to know, but are nice to know, are pulseless VTAC, VFib, PEA, which is pulseless electrical activity, asystole, symptomatic bradycardia, and unstable tachycardia. So here is just your generic cardiac arrest. And again, this is nice to know. This is what you would do with a patient who's pulseless. I usually say, like, the ones that have blue means the patient's dead, they have no pulse. Whereas this one is green. So this one, the patient does have a pulse. They're symptomatic, or if they are symptomatic, you could follow this. But and once you give the atropine, your next alternatives are transcutaneous pacing, which seems to be probably the most common. And then you could give dopamine or epi infusions because they do cause tachycardia. So it would increase your heart rate just based on those side effects, right? Here is adult tachycardia with a pulse. Again, it's green. And both of these, here's persistent bradycardia causing, these are the unstable things in this like salmon or pink colored box. It's the same really. But if the patient's unstable, they may be exhibiting some of those things. So you want to look at those symptoms, those signs and symptoms to see, is your patient stable or unstable? If they're unstable, you're probably going to be moving to some kind of an electrical option. If they're stable, then you can try vagal maneuvers, which could be bearing down, possibly giving medications like adenosine or calcium or beta blockers. And at this point, if the patient is stable, you have time to get an expert consultation, probably a cardiologist or an electrophysiologist to get involved. If the patient's unstable, you're moving pretty quickly to cardioversion. Now, if it's going to take you a minute to get the monitor set up, maybe you're not that familiar with it, and someone happens to already have some adenosine ready to give, you could consider giving adenosine. But you don't want to delay synchronized cardioversion for adenosine. Preferred basically is the cardioversion. Adenosine is a consideration if there's a delay with the cardioversion. So, and this, the box above does have some specific directions on dosing and details regarding that. And this could also be something that, experts may weigh in on too. So once you do get return of circulation, return of spontaneous circulation, or ROSC, here we want to improve their function. We need to get them to an ICU if they're not already. And then we really want to try and figure out what might have been the culprit so that we can fix whatever we can fix so it doesn't happen again. So in general, the first thing you're going to do is, are they breathing? A lot of times when they get their pulse back, they may not be breathing. So you may have to continue to do respiratory rescue breaths by bagging them with the ambu bag. And at this point, how long are you going to bag them for? I mean, we can't just bag them indefinitely. So at this point, we may consider putting in an advanced airway like an endotracheal tube. We want to know, what is their blood pressure? Is their blood pressure reasonable? American Heart Association pretty much says if their systolic is under 90, then we probably want to treat it. Now, certainly that's a guideline, and but in general, if you're going to treat it, you're going to start with some kind of an isotonic crystalloid bolus like normal saline or LR, and if that's not effective, then you may start with a vasopressor. And we're definitely looking at the oxygenation. What's their pulse ox? Once you get that advanced airway, we really probably need to be looking at their end-tidal CO2 acid-base balance, kind of give us an idea of how they're doing. We want to look at their rhythm. Are they having any dysrhythmias? Here's a good time to get a 12 lead. Can't do it when they're getting compressions, but we can definitely get it post compressions, right? Here we want to know, what is their neurofunction? Because this is going to determine whether or not the patient's going to get cooled. So if they have some neurofunction, they're not getting targeted temperature management. But if they do have, if they're unconscious, if they have no responsiveness, then we are going to cool them. And I'll go over that here in a moment. I already talked about capnography and targeted temperature management. So let's move along. This is what capnography looks like on the monitor at the top. So this actually can be used as a means of evaluating how good your CPR is, because if your capnography is not above 10 during resuscitation, then your compressions are not good enough. So that is a good number to know. And this is also something that does get evaluated and does need to be listed on the code sheet for any code that lasts 10 minutes or longer. There needs to be some sort of capnography recording listed. So if your capnography, if your end-tidal CO2 is under 10, it's time to tell that person, pick it up, go faster, go deeper, or switch compressors, see does that make a difference, that sort of thing. So there are some patients who do arrest after cardiac surgery. So for our cardiothoracic unit at UH, you may have and see a different means of resuscitation, because once they've cut the sternum, they often don't want to push on that recently separated sternum. So they may actually reopen the patient's chest and manage the patient a little bit differently. So they may go with pacing wires, they may go with opening the patient's chest and, squeezing, but this is going to be different. And again, it's because the sternum was cut. So their means of resuscitation for those post cabbages. Feel free to ask your nurses that you work with, what they do and how they manage that. Targeted temperature management, we used to call it therapeutic hypothermia. There was a study that came out a few years ago where they looked at maintaining that cool temperature of 32 degrees versus maintaining 36 degrees normothermia to see if there was a difference. And actually they found that that there really wasn't a difference. What was the big thing is they want to avoid having a temperature. They don't want the patient to be febrile. That increases your metabolic rate, and that is the problem. We want these patients to have a chance to maybe have some kind of neurologic recovery. This actually started with neonates before the adult world kind of picked it up. But in general, a fever can cause worse neuro outcomes. So we try to avoid that by cooling patients. I think this generally works better in patients that have like VTach and VFib arrest versus PEA and asystole, but we still do it for PEA and asystole. Everybody gets a chance with this, but we keep them cool or normal thermic for 24 hours, and then we'll do that slow rewarming over 12 to 24 hours. And again, what this means is the machine, the Arctic Sun, or I forget the name of the other machine, it's on the next slide, will basically maintain it. If you're hypothermic, it will gradually raise your temperature by like a quarter to a half degree Celsius per hour. And it will do that over this time frame. But the big deal is we just don't want them, again, to become hyperthermic at all. So, and the reason why we rewarm them slowly is because we want to reduce the chance of sudden vasodilation, which could lead to hypotension and shock. So we want to, in a very controlled fashion, rewarm them. And we do start this targeted temperature management quickly, immediately. We do monitor their temperature, their core temperature, which means we put in a Foley that has a thermistor on it that can be attached, or we can put in an esophageal probe to measure their temperature. Now, if you have a patient who is anuric or getting dialysis, probably the Foley bladder one is not the best option because they may not have urine in there to like transmit that temperature. You may want to go with like the esophageal probe. Here's the picture. I don't remember the name of this machine, but I'm sorry. This is the Arctic Sun. I apologize. And you can see in the picture of this patient who's demonstrating, it's supposed to cover about 40% of the body. There's gel pads on the inside, and water that is cold and regulated by the machine flows through the gel pads, and that's what cools the patient. But they wrap around to their back, so it covers their chest, abdomen, and their back, and then their thighs, which is a rather large surface area. Now, the picture on the bottom, that's the machine I can't remember the name of. They actually use an internal method of cooling. So the blood flows out, is cooled through the machine, and then it flows back into the patient. So they chill them on the inside. And patients can shiver, and we really don't want shivering to happen because that can increase oxygen consumption and metabolic rate. So we don't want shivering. So we may actually kind of cover them up to kind of avoid the shivering, or we may give them medications. But we are going to be assessing them for shivering a lot. A PA catheter also is a source for a core body temperature too. But here we're not doing like oral temperatures or axillary temperatures. Those are not core temperatures. Patients will be sedated and given analgesics. And this patient, he has EEG leads stuck to his head, and those are for monitoring for seizures. So anybody who has targeted temperature management will have continuous EEG monitoring as well. Complications of TTM or targeted temperature management: bleeding, infection, and electrolyte disturbances. And you can see listed with the cooling and the rewarming when the electrolytes may be lower and when they may be higher. And certainly hyperglycemia, typically related to any kind of catecholamine release. So, and that can be, like a stress response from this arrest and incident. So if you have a code and the patient next door, maybe they're separated by a curtain, or, maybe they hear the goings on, they see all the people, maybe they see across the hallway, as best you can, you kind of remove them from the situation. If they're right next door and there's a door to close, please close it. Let them know that that the patient next door is encountering an emergency. We're really not allowed to share specific information about the patient, but you can say we're having an emergency on the unit, or the patient next door is having an emergency. So you're going to see a lot of activity next door, but we're doing our very best to take care of them and respond to this emergency. You will find that, the rooms get very full of people, and you do need to have nurses in that room, but not all the nurses need to be in the room. We do still have to have some nurses outside the room taking care of the rest of the patients, because we work on big, sick, busy units. We do encourage family presence during a code. Some nurses feel like they might not want to see, or it might be difficult to see, but it's an individual thing. This is something that you can offer them. Would you like to come? Would you like to see what we're doing? Some patients may say no, they may not want to see. It might cause them more anxiety and distress to see it, but if they want to see it, they absolutely can come back, but somebody should be with them, somebody who can explain what's going on. So that's probably not the secretary or even though they're very well knowledgeable, but it may not be the CT. It probably should be a nurse or a provider who is talking to the family about what is going on and can explain what they're seeing. For the most part, in my experience, family have not been disruptive, but sometimes they are. You can set limits with them. They may not realize that they're in your way. They may just be kind of in their own head, and they're suffering this huge grief event, and they may not be aware of what else is going on. So, if you let them know, I'm sorry, but can you just move 2 steps to the side? We really need to get in here so that we can do whatever. And I find that, most families who see us doing all of these things to their families, they tend to recognize that we are doing everything for them. They do tend to terminate efforts a little faster, I think. And it also helps them in their grieving process to have seen this. Yeah, benefits. So they see this. I kind of already, went over this. Helps with their closure and such. This has been such a challenge with COVID because the visitation has been restricted. So this has been very difficult for the nurses, for the families, for the patients, for everybody. We do make exceptions with end of life when they are like a DNR comfort care. We do allow more families in. We make exceptions during that time, but if it's a sudden onset full arrest, the family may or may not be there. They may or may not have enough time to get there to see their family member, to be present for that. At the Cleveland Clinic, we do a pause where we take a moment of silence We used to just have a moment of silence, like for 30 to 60 seconds, but now we actually have a, a statement that someone reads to kind of respect the person who's lost their life and kind of recognize, here's the pause. So for an adult, someone would say, let's take a moment to pause and honor Joe Smith's. He was a person who was loved. He loved and was loved, and he was somebody's family member and friend. In our own way and in silence, let's just take a moment to honor Joe. Let us also honor and recognize the care of the team, the care that was provided by our team. Thank you, everyone. And then you take that moment of silence. And there is actually one for children, which I saw the other day and took a picture of. So I assume other hospital systems have something similar. We do want to debrief after a code, and you want to do it right away. Maybe with the team, maybe with the supervisor, but somebody should really do a debriefing. And in this, we're looking at what went well. What did we do well? Clinically, teamwork, communication, leadership, anything other. And then what could we have done better? Because here's the time where we may find something that was a barrier, a latent threat that we may have uncovered that we could fix for the next one, for the next code. And a lot of times we're looking at the American Heart Association guidelines, the Get With the Guidelines. Was high quality compression started within 1 minute? Did the patient get defibrillated within 2? Did they receive a dose of epi within 5 minutes? Did we confirm the endotracheal tube by end tidal CO2? So these are things that get looked at in every code. I know the Cleveland Clinic, any patient that receives even one chest compression, their code sheets get reviewed throughout the enterprise by a critical care response team. And they do look at these and they want to know, why didn't that patient get their defibrillation in enough time? Or, they may have questions, and it's not like a witch hunt where they're trying to blame everybody. Mainly what they're trying to do is see, does this area need education? Are there things that we can do to make this better? What was the holdup? What was the hang up? They're not so much trying to place blame. It's more of a just culture where they're trying to find out, what could we do to prevent this from happening again? And then some new things. RQI, which is resuscitation quality improvement. I know they use this at UH and the VA. I'm not sure what Metro uses, but the diagram on the top left, they may have that out in the hallway. And I think usually it's quarterly. The employees all have to go out there and do their thing on the machine, answer some questions, do some CPR, and that's their quality improvement check. Instead of taking BLS, this is their means of renewing their BLS. The bottom left picture, that's a picture of a Lucas device, and we have quite a lot of these now with COVID, in efforts of trying to reduce the amount of personnel in the room needed for resuscitation, but they have been used in squads for decades. So anyway, all right. Well, so that's our little spiel on rapid response and code team management. We'll go over some H's and T's scenarios in class on Tuesday.